My name is Marguerite Massinga-Lwembe. I'm a senior science manager at ASLM, and I wish you a warm welcome to our session today, which is co-organized with the TB-CAPT consortium. So today, the topic of our ECHO webinar will be the LAM assay. As many of you know, as an aftermath of the COVID-19 pandemic, the diagnostic gap for TB has increased, and many countries have been faced with a reversal of the progress they had achieved towards the targets of the NTB strategy. In 2021, specifically, of the estimated 10.6 million individuals who developed TB, only 6.4 million were diagnosed, which gave us a gap of amounting to about 4.2 million cases that were not found. Faced with this situation, there is an urgent need to reverse this trend and expand access to rapid and decentralized TB diagnostic tool, as well as exploring the range of alternative specimens other than sputum, which can be tested, including for key vulnerable population that are the people living with HIV and the children. As has been stated in a commentary published this week in Nature Microbiology, if you cannot find the TB cases, you cannot treat them. And if we cannot treat them, we cannot end TB. So I would encourage you to read that excellent comment, which was published by Madhuka Pai and colleagues. The TB-CAPT consortium is comprised of 14 leading organizations across 8 countries, and including ASLM. The TB-CAPT consortium is funded by EDCTP, and it is coordinated by FIND. The objective of the TB-CAPT consortium is to run a range of trials to evaluate the impact of diagnostic intervention to close the gap, increase access, in order to provide access to adequate therapy and treat TB. One of the interventions that is currently being evaluated through the TB-CAPT consortium is the LAM assay, which was first recommended by WHO in 2015, with a recommendation to expand its use in 2019, specifically in people living with HIV. So today we are very happy to welcome experts, which will walk us through different aspects pertaining to the TB LAM diagnostic assay. And so first we will have Professor Leslie Scott, the head of the research and development at the WITS Diagnostic Innovation Hub in Johannesburg, South Africa, who will provide us with an overview of the TB LAM diagnostics. She will be followed by Dr. Morten Rouwer from the TB program at FIND in Geneva, who will provide us an overview of the TB LAM technology development pipeline. This will be followed by a presentation on operational aspect of TB LAM testing. This presentation will be provided by Professor Jeremy Neal of the Division of Infectious Disease, Department of Internal Medicine at the University of Witwatersrand, Johannesburg in South Africa. And finally, we will have a last presentation on quality aspect and approach to develop a robust TB LAM quality assessment program. This presentation will be provided by Anora David, Senior Medical Scientist, also at the WITS Diagnostic Innovation Hub in South Africa. And finally, we will be ending with the question and answer session at the end of our ECHO webinar. So without further ado, I'm handing over to Professor Leslie Scott to take us through the first presentation. Thank you.
Thank you very much, Margareta, and good day to you all. Thanks for the introduction and the overview. I think you've really covered it from my side, Margareta. Thank you. But I'm glad to be able to pull together several experts in this field. And as Margareta mentioned, we'll be focusing on the lateral flow the LAM diagnostics, looking at the pipeline, the clinical adoption in the field setting, particularly in South Africa, and strategies for quality assessment. And Margareta, I'm so glad that you mentioned the TB-CAPT consortium. Our group is part of that. And actually, LAM became really the focus for the enrollment criteria for several of the clinical trials in this multi-country evaluation. And so that really started the conversation around the need for quality and the role of laboratory and clinical diagnostic quality approaches in field settings as well. So I'm not going to reiterate the different aspects and who will be presenting. They'll follow me shortly. But I wanted to mention, and actually, Margareta, you highlighted this, thank you, the Nature Microbiology comment from Medica Pi's group that really shows the massive gaps still that remain for TB diagnostics. But I wanted you to look at their 7 lists. And if you look through all of these, diagnostics are key to all of them. We need to move closer to molecular diagnostics. We need to use both decentralized point-of-care NATs. We have to look at multi-disease testing. We need to look at alternative specimen types. I've highlighted urine, particularly for our LAM talk today. We have to move closer to communities and homes. We have to look at active and pre-care seeking. And of course, the focus is on yield and population coverage. And we know that diagnostics are the weakest link. And of course, low cost, high volume, and LMIC manufacture are really the 7 key focus areas that are being proposed as the only ways that we can address the weakest aspect, which is the diagnostics. And key to this talk is really the quality, the need for quality across the diagnostics, across all these settings. So I wanted to just also reiterate the latest WHO guidelines set in 2019. And it's really, I don't have to tell this group about the importance of the 2 settings, the inpatient settings with strong recommendations for use to assist in the diagnosis of active TB and HIV-infected adolescents, adults, adolescents, and children. And this really is those with signs and symptoms of pulmonary TB, extrapulmonary TB, advanced HIV disease, those that are seriously ill, and those with CD4 count less than 200. And then in the outpatient settings, really a conditional recommendation for the use to assist in the diagnosis of active TB and HIV-infected adults, adolescents, and children. And again, signs and symptoms of pulmonary TB and extrapulmonary TB, seriously ill, and those with CD4 counts now at less than 100 cells per microliter. So again, very clear guidelines. And I couldn't help but go back to the literature. And even Morten and I spoke this week to say some of the first papers that came describing LAM more in an ELISA-based format were really presented in 2001. It's a long time ago since the guidelines were changed and implemented. And if you look across the 155 publications that I randomly did in a PubMed search, the 62 of them were published during the COVID era. And just having a look at the types of those publications, it's really around modeling and diagnostic value, including the uptake, the impact studies, and the use in extrapulmonary TB. There's been quite a lot of work on meta-analyses in children, several cross-sectional studies. In fact, across 4 of the African countries was a great manuscript. Alternative specimen types really showed quite heavily in this publication group. And again, a multi-pathogen detection and multi-pathogen approach. The multi-assay use, so several publications looking at LAM and expert in several settings. Of course, there's a lot of interest around the Fuji LAM, the accuracy, and there's a systematic review. And then a lot of work, and I know that Morten's going to mention this further, is the new LAM structure and other biomarkers and antibodies, how to improve the current assay performances. And I was quite pleased to see that there are also several publications on user perspective and field feasibility. So I urge you to go and look at some of these. It also puts it in context, I think, for potentially improving and moving forward to new guidelines in the near future. But across all of these, I have to say that quality assessment for the LabCoP LAM seldom featured. It's not an easy topic to decide where to look at quality, how to implement it. And I think a group like the ASLM would be beneficial to focus on these aspects. And I hope that we can get valuable insights from our speakers today. We know that the quality management systems beyond the laboratories are not well translated. And in the context of LAM being used in field settings, this really needs a good framework, and it needs to be scaled to field settings. So without further ado, I'd like to hand over to our next speaker. You've introduced him before, Dr. Martin Riebold from FIND, and we look forward to the next updates on the diagnostic pipeline development. Yeah.
Brilliant. So thank you very much for this kind introduction, and a really nice basis to continue talking about this fascinating molecule, LAM, and the global efforts there are to develop new assays to detect it. So as I said, my name is Morten Ruwald. I'm Director of TB at FIND in Geneva, and over the past 6, 7, 8 years, FIND has done a lot of research on sort of supporting manufacturers and academic groups to move this marker forward. So, as Leslie mentioned, we have the LAM here. That's the currently the only commercially available LAM assay. We know the sensitivity of this assay is not perfect, but it has really a niche in people living with HIV with an advanced disease or very low CD4 cell count here, implementing LAM in workflow in slides. But looking at it sort of in the people living with HIV, where this test performs best, a sensitivity overall of 35% is probably one of the lowest sensitivities among commercially available assays. So Fuji LAM was then expected to be what we call a second generation LAM assay. It's actually a little laboratory inside a piece of plastic that has a lot of it takes a long time to sort of flow through this, but it has a visual readout. And as Leslie was mentioning, lab studies and frozen samples suggest sensitivity would be around twice that of the LAM, and really perhaps allow us to take this assay into a larger population of people living with HIV, perhaps even up to 500 CD4 cell counts thereabouts. So we worked very closely with the Japanese funder and partners across many countries, Malawi, Zambia, Uganda, Tanzania, Vietnam, Thailand, to do a very large clinical trial aiming WHO policy recommendation last year. So we were switching between all of these countries, and we also had a good representation of inpatient and outpatients to really define that use case. We ended up with around 300 participants with confirmed TB and about 1,300 who did not have TB. We saw similar sensitivity as was found in the other studies, in the previous studies on the biobank samples. However, we couldn't really understand the specificity of this test was lower than expected. And we did sort of a root cause analysis looking at all the different parameters. Was it something in the labs, or was it something with the participants, or the country, or something like that? But in the end, we actually found that the underlying cause here was big variability in the 6 individual lots that were supplied to this study. Some had high sensitivity but was low in specificity, and others, like this one here, very low sensitivity but very high specificity. And as a clinician, you wouldn't really know, did you receive this lot or this lot? So of course it was not ready for a commercial launch yet. So WHO cancelled a WHO policy review. The manufacturing issue was identified and resolved at Fuji, and the test is now being redesigned and expected to be relaunched this year. So why is it so difficult to make a good LAM assay? Well, I think one of the challenges is around this structure of LAM. It's an abundant glycolipid on the outer surface membrane of bacteria. It kind of has a lot of these branched out areas you could use for good epitopes for antibody binding. The challenge is that this is how it looks on the surface of the bacteria, but when we find it in urine, it's fragmented into many smaller bits. So it's about finding good antibody pairs that actually captures good fragments and also epitopes that are specific. Then there's also a lot of challenges around urine as a sample matrix. The LAM concentration is incredibly low, and it's really bordering the lower limit of detection you can push out into a lateral flow kind of test. We know more and more about LAM. It's present in urine, that's a fact, and it's perhaps present in almost all patients with TB. It's correlated with the extent of the bacterial load in the patients. We also find it in blood. We find it in sputum. We find it actually also recently was shown in a really nice paper from a group in Toulouse in France that you can have an exhaled breath condensate. You find a LAM also there, and it has a different kind of structure or different MAN-CAP structure than the LAM found in other compartments. But so there's advantages and disadvantages, and clearly urine seems to be the simplest approach, and that's where most of the commercial pursuit is. So there's sort of three different types of LAM assays being pursued. One is like the FujiLAM, where there's a visual read, you have your eyes and you don't need anything else. Is there a line or is there not a line? It's a classic sort of gold particle-based lab. It's simple, robust, tried in many other tests. But then if you really want to get a good performance, take this beyond just the people living with HIV, you probably need to either concentrate the sample, extract LAM from the sample, as it's being pursued by many groups here, including Abbott, who are working on a new version of the LAM. But it has, of course, multiple steps. It makes it more complicated, higher cost. Or you could use a reader that using fluorescently marked antibodies can increase the sensitivity. And there are several manufacturers also pursuing this. So to end this the story, we have the LAM. It has a narrow use case, but definitely saves lives, and it is underutilized. We have the FujiLAM. The clinical evidence shows that there is better accuracy than the older LAM, but we had this issue with lot variability, and we're still now waiting to trial the new version of the Fuji test. And then we have actually quite a lot of relatively advanced products that we expect to be ready for clinical trialing through 2023 or early 2024. We have secured a grant from Unitaid and are working with many other academic groups to really accelerate clinical trialing when these becomes design locked and released from that factory. And with that, I just would like to say thanks to particular Harisha and Chandra from the FIND team who's helped me put these slides together, and all the funders and everyone at FIND, and partners across the world working with us on LAM and many other assays.
Okay, I'm Jeremy. Welcome, and thanks very much. I'm going to be just talking about operationalizing some of the LAM tests. We've been fortunate enough where I work to have LAM for many years, and I'm going to show you some of the challenges and trickiness that we've discovered, and what sort of solutions we found, with the assumption that you will have different solutions at your settings when you roll out LAM, and you will have found some solutions yourself for those of you who already have access to it and rolled it out. I wanted to set the scene. So I wanted to just tell you about the site where I work. The hospital is in Johannesburg in South Africa. It is a tertiary hospital with about 500 beds. We work in the infectious diseases division. We see about 750 consults a year, inpatients, and about 6,000 outpatients every month are seen through our division. Relating to the types of patients we see, about 42% of our medical admissions are people living with HIV. Those patients who do have HIV have a median CD4 count of about 67. About a quarter of those people living with HIV and admitted have been diagnosed for the first time during this admission that we see them. And of those people who are previously diagnosed with HIV, about 3/4 are on treatment. But of those on treatment, about half are failing antiretroviral therapy. So in other words, we're seeing many people with advanced HIV disease, either because they haven't been diagnosed previously, or whether or when they have been diagnosed previously, many of them are failing antiretroviral therapy or are not on treatment at all. So we're seeing, as an inpatient service, all those patients who have failed through the healthcare system. In other words, the healthcare system has failed them and they end up with a very low CD4. It does mean that many of our patients obviously would benefit from a urine LAM given their advanced HIV status and the high burden of HIV in our patients. In our cohort, about 40% of patients had an AIDS-defining condition. And specifically, TB was present in about a quarter of those people living with HIV. But there's a limitation of this particular study. It's probably close to a third of the people living with HIV who enter our inpatient service who have TB, so a lot of TB. We have always had it as a clinician-performed test. Well, we started it as a clinician-performed test. And some of the challenges which came up, some of them may amuse you because they sound funny, at least if you're based in a lab and you can imagine poor clinicians running around trying to, or messing this up. But one challenge is that you're supposed to read the urine LAM strip. This is the Alere LAM strip that we're talking about, the commercially available one, between 25 and 35 minutes after adding urine to it. That turns out to be a very difficult thing for clinicians to manage because they don't have 25 minutes to wait. So in practice, what happens is they'll add the urine to the strip, then go and see some patients quickly, and then come back around 25 to 35 minutes. But that often is inaccurate because something may have cropped up. Maybe the patient there was some emergency and they had to attend to. But this is not something that you could, for example, just set an alarm and wait around and read at the right time. It also is difficult if you have multiple patients because each clinician may have 5 to 10 patients to do. And so in other words, you could collect 5 to 10 urines and try and do it all at once, but it ends up being, again, quite logistically difficult when you have other patient care that needs to go in between all of that. Some of the other issues which have been addressed now at a global level, but were about what to do about interpreting these faint lines. As you know, the original LAM strip had five lines. And then there's problem with the sort of grade 1 cutoff, the very low, the faintest lines was a very poor specificity. And so now the new card has tried to solve that problem, but we still have clinicians wondering about this faint line here. And basically, what if you see something a bit fainter than that? Now, this is answered in the guidelines. There is an answer to this question, but the challenge, of course, in a clinical setting is that most of our doctors rotate across hospitals every 3 months. There's a requirement for repeated training and people forget. And so this is not always available. Another thing is, again, there is an answer to this, but these are some of the challenges which have been seen, is the urine volume. So it's meant to be about 60 microliters. We have those bulb pipettes on the left there of your screen, which can be used. And those bulb pipettes are about 60 microliters. But again, the clinicians, some of them add 1 drop, some of them add 2 drops, some of them add the whole thing. And there's not a lot of standardization here that would go on naturally. Again, what we're seeing again and again is the challenge of running a so-called bedside test or something by the patient from people who are not skilled in lab procedures and not always well trained, even if you do formal training. Other issues which crop up, again, not something that can't be solved, but something that is interesting because it keeps cropping up, is about stock control. So if you allow, we have hundreds of clinicians, and if we hand out the strips, they tend to disappear very quickly because people will take a whole bunch at once. And then it's not enough for the next person. Someone has to control the stock. Someone has to order more LAM cards and more LAM strips. The card itself, there's only one card per pack that often gets lost or taken, and the pipettes similarly. So again, nothing that can't be solved, but this is a reality of what happens when you do it in an unstructured manner where any clinician could do it with minimal training and without sort of any central control. Choosing the right patients may be difficult as well. In the slide here is a comparison between the South African national guidelines and the old and the new ones, and the WHO guidelines in the center there. I don't mean to read through them other than just to highlight that especially, and this is really a problem mostly from the South African side, where the guidelines have changed recently and frequently and are different from WHO in subtle ways, that this can again confuse clinicians who, again, remember, this is not their primary job. They look after people with diabetes, hypertension. One of their many, many, many jobs is to look after people with HIV. And it's very difficult. I actually prefer the WHO ones above the South African ones. But again, just the fact that they're different is another challenge in setting. So again, speaks to the need to really be really clear about guidance and have it easy to remember. If you have to look up, and for people who don't do this routinely, if you have to look up who qualifies and who doesn't, that's not ideal in a guideline. And then last set of challenges were around the interpretation of results. We know this again, but again, this is a fact that we've had to reiterate again and again with clinicians, that a negative result obviously doesn't rule out TB because the sensitivity is low, and on a high burden setting like South Africa, the negative predictive value would be very poor. And clinicians may struggle with that. So for example, it's intuitive to say, well, I thought they had TB, I did the LAM test, it's negative, now they are quite a lot less likely to have TB, when in fact that may not be true depending on the particular scenario. And then more subtly, a positive result doesn't necessarily mean it is TB. We know you get false positives with disseminated non-tuberculous mycobacteria, as well as other organisms. And that actually has not been addressed well at any level through WHO or through the South African guidelines about what to do in the setting. In our hospital, for inpatients who test positive with the LAM, we routinely actually do mycobacterial blood cultures, and we find a very significant proportion, a minority, but a non-trivial minority, around a quarter of them with CD4 less than 50, end up actually having a non-tuberculous mycobacterium. So it is a challenge which hasn't been well addressed at really any level. And then the last challenge being recording the results. Again, this sounds trivial, but it's a reality of having a test which is not lab-based. In South Africa, in the state system, all the lab-based tests become digitally recorded, and you can access them across the healthcare system. So if a patient goes to a particular clinic and then they come to my hospital, we can find the result usually from that clinic, as long as the records have been entered correctly. That's obviously not the case when you do urine LAM, because it's not done in our setting by the labs. It's done initially by the clinicians. So it's certainly not intrinsically true. You can handwrite the result in the file, of course, but that means when a patient comes back, you have to have quick access to the file, and you have to, and of course, it doesn't solve the problem of patients moving between facilities where they won't have access to that original hospital file. So what solutions did we choose and I'll just take you through what we decided to do at our hospital to try and solve some of these problems. One is that we decided that, despite it meant to be a clinician run test, we decided to centralize who performs it. So we chose 2 dedicated nurses who were trained in this technique, and we assessed them and made sure that they were reading these strips reliably. So for example, we did audits of them and performed the test ourselves to double check that they were accurate. And we had 2 people who basically were able to do all the LAMs in the hospital, despite it being quite a big hospital and quite a number of patients. It really actually requires probably only 1 dedicated person per day. But we chose 2, of course, in case one is sick or on leave or something like that. But you can actually manage the volume with just 1 person, at least in our setting. And what happens is the test is performed so-called opportunistically. In other words, this is actually, they don't just sit and wait to do the test. They're busy in the TB clinic in general. And then several times a day, say perhaps every 2 or 3 hours, probably let's say on average every 2 hours, they will go, they'll collect all the LAMs that have been dropped off, the urine samples that have been dropped off, and do urine LAM testing on all of them. In practice, that means the turnaround time, even though the test is, say, 25 minutes, the turnaround time in practical term is somewhere between 1 and 4 hours, because obviously it has to be collected, then dropped off at the central location in the hospital, and then that won't necessarily be performed immediately. It may be performed 1 or so hours later, and so it ends up taking 1 to 4 hours. The interesting thing is that this almost never matters. And that's worth reiterating, because it's lovely to have a test that takes 25 minutes in theory, but you say, but okay, but if you do it this way, it takes 3 or 4 hours. Remember, these are mostly inpatients they're being done on. Very few people are waiting for this result. It almost never matters certainly when it's inpatient, because it's almost never that you need a TB diagnosis within a few hours. It's not like a Staph aureus bacteremia or some meningococcus or something like that, when you really do need a result immediately. Here you can wait, especially on the inpatients. Outpatients who are waiting for the result can be prioritized to get the result sooner though. So what happens in practice is that the doctor involved with the patient will collect a urine sample. They'll drop it off at our central TB clinic area in the hospital. They record on a sheet there the patient's details that go with the urine, and then their own phone number from the doctor's side. The trained nurses will perform that LAM, and then they will phone out the results to the doctor and also transcribe the results in a central book at the TB clinic. This is not an ideal solution. It would be nice to be able to add it electronically to the lab system, but this is not possible in the setting where I work, at least currently. So instead, what happens is the results get phoned out telephonically, but also a written record is kept in a book, so anyone can come back with time and search for particular patients' results and validate, or at least reassure themselves that what was phoned out was correct. Again, it is not the best solution, but it is a workable solution. And then, so if I list all of the problems again, just as this is our last slide, really, of what the problems we identified and what the solutions were, many of the solutions can be found in really just training people to perform them regularly. So it doesn't have to be 1 or 2 people. I would suggest minimum 2, so that they, depending on your settings, so that if someone's not around, the test doesn't have to stop. But we really have found it's very useful to centralize within the health facility who performs these tests, in terms of reliability, in terms of timing, interpreting the lines, the urine volume, also stock control, and making sure that everything is ordered correctly. With regards to patient selection, choosing the right patients and how to interpret that really requires doctor training. We do then, and we go through, and this is part of our formal teaching every few months, that we give our doctors to try and improve the knowledge of how to interpret this and which patients to select. And then, of course, recording the result, as I said, is recorded in one central book, which is, again, not ideal. It would be nice to add this electronically to the patient record, but we don't have the ability to do that at the current point. So in conclusion, we have found it a really, really useful test to have in our hospital. We've had it for many years. It's been delightful. We've solved many mysteries this way by having this test, and really does have great implications in terms of patient care. But the problem is the reliability of allowing any clinician to do it, even with training, when there's a high throughput and when you don't have constant number of staff, when they're moving between facilities every few months. And so we found that really having dedicated people, in our case nurses, to get trained on it really solved many of these issues. It doesn't really increase the workload because it's a quick test to do, especially if you batch them, and it vastly improves the reliability of these tests. And then training healthcare workers on patient selection and the implications isn't hard, but again, really does need to be done. It's a subtle test in the sense that its results can be quite difficult to interpret, even though on first glance that it doesn't appear to be the case. And I'm going to end there, and I very much appreciate that solutions at different healthcare facilities will obviously be different, but I thought it may be valuable to show what worked for us in case something similar may work for you. Thanks very much.
Thank you, thank you. And then we're going to move, I see we have some questions, but we're going to move first to the last presentation by Anura on the quality aspects, and then we can take a round of questions. So Anura, the floor is yours, please.
Thanks, Marguerite, and thanks everybody for this opportunity to present today. So I'm Anura, and as Marguerite mentioned, today I'm going to be speaking to you about our approaches to developing a robust TB LAM quality assessment program. So just a bit of overview, I'm going to be taking us through QMS in a lab environment, a little bit on the QA overview, importance of QA, a little bit on the CDC EQA survey, our experience with LAM QA material development, considerations for LAM EQA, result reporting, the role of digital health technologies, result return, and summary and some acknowledgements. So we know that in a laboratory environment, the quality management system is usually very well implemented. It's something that everybody in the lab is very much aware of, and it basically ensures the reliability of all aspects of the operations. So there are 12, excuse me, there are 12 components of the quality management system, and these range everything from organization to personnel to equipment, the purchasing and inventory, process control. And assessment is actually one of these components, which consists of planned activities and is important for improvements of the laboratory quality management system. So EQA basically can be done using 3 different methods. The first is proficiency testing, which basically occurs when an EQA provider provides samples to a lab, who tests these samples, return these results to the EQA provider, who then analyzes them and provides a report back to the lab. The second method is rechecking or retesting. This is more of an inter-laboratory comparison. And what happens here is that you have slides that are tested at a lab, and they are then sent to a reference lab for rechecking of these slides. The third method is on-site evaluation, which is usually performed when it is difficult to conduct traditional proficiency testing or if rechecking is not an option. So this basically occurs within a lab when a more senior staff member or somebody with more experience in reading slides, for example, reads them from a junior staff, reads them after a junior staff member has read them. So what are the benefits of EQA? So it allows comparison of performance and results amongst different test sites. It provides an early warning for systematic problems associated with kits or operations. It provides objective evidence of testing quality, indicates any areas that needs improvement, and identifies training needs. So as I mentioned, in a lab environment, this is very well documented, it is well implemented. But what about point of care tests and in field settings? Do the same rules apply? So the importance of QA, especially with regard to lateral flow assays in the lab, quality assessment is extremely important for these lateral flow assays because the nature of result interpretation relies on operator competency. Because it is the operator that's actually reading these strips. And as Jeremy said, you know, it's these faint bands that are sometimes on these strips. So you have to be competent in order to interpret these results. So this requires proper training, SOPs, as well as quality control to ensure that quality results are being reported. But even within a laboratory environment, we know that there are challenges. For example, there are limitations of the assay itself. And I'll be speaking a little bit about this more as I speak about the LAM testing in a little while. In field testing, it's a little bit different because here, as Jeremy mentioned, it is not trained lab personnel that are performing the testing, but it is actually non-lab personnel, which include nurses and other healthcare workers. So the advantage of doing these tests in the field is that it offers an advantage of reduced patient waiting time. But then it also comes with its own set of challenges. We know that training and competency is usually inadequate in these settings. Reagents are often inappropriately stored, and they may be reagent stockouts if the stock is not well maintained and controlled. And also there may be a lack of supportive supervision. So we have learned some lessons from the HIV lateral flow QA programs that have been implemented. What we've seen is that there's usually poor participation from healthcare workers. There's also a lack of focus on ensuring the quality of HIV tests performed at the community level. But if you look at a quick review of the literature has also shown that these factors can be improved through the provision of additional resources. So providing training, implementing or providing supervisors and coordinators to ensure that these QA programs actually proceed effortlessly. And then there was a recent stakeholder sensitization meeting, well, relatively recent, in September 2022, which the CDC hosted, and they basically wanted to find out, or basically sensitize members to a survey that was going to be sent out to determine whether LAM EQA is actually required. And in these initial discussions, there were a lot of concerns raised, some of which included the fact that it's not easy to actually implement the LAM. So as Jeremy mentioned, there were numerous problems that they came across when they had to implement, and they had to come up with solutions in order to make sure that this worked. Another issue was that there's a poor uptake of LAM. So in September, it was reported that approximately 20 countries had implemented or were in the process of implementing the LAM test. There were also concerns about the performance of the assay, also regulatory delays. So we know that it's not easy to implement any assay in a country. There's usually some kind of in-country approval that's required. There were concerns about waste disposal, as well as the ease of urine collection in decentralized centers. So on this point, I just want to mention that we've recently performed a feasibility study. Well, this is basically more to look at oral swabs for TB diagnosis, but we asked participants on what their response was with regard to the collection of urine. This was done at a primary healthcare facility in Johannesburg, and greater than 95% of participants reported a clean, safe, and suitable space to produce a urine. And this was a study that was performed on 330 participants. But again, this was just a single facility. Another fact, or another point that was raised was that there are no guidelines available for QA of LAM testing. So this survey was sent out in late 2022, and I tried to get onto the CDC website to check if there were any updates, and I haven't been able to find any. But if anybody in the audience has any updates, please share with us so that we also are kept up to date with what's going on. In 2020, we were awarded a WITS Biomedical Innovation Award for development of an EQA for the LAM assay. So what we did is that we worked with urine as well as inactivated cultures. We tried different methods of inactivation. So this included heat inactivation and chemical inactivation using commercially available inactivation buffers. We also tried using sonication using a tube sonicator and heat inactivation using an autoclave. We also tried using meat material, different dilutions, and we also performed stability testing by storing these inactivated material at -20 degrees at ambient temperature, at 2 to 8 degrees, and at 37 degrees Celsius. So what we found was that heat inactivation worked well and was more cost-effective than chemical inactivation. For the material that was stored at 37 degrees Celsius, the specimens evaporated after 25 weeks of storage, so this was not an ideal temperature. We also performed pilot testing of material both in the field, with testing performed by healthcare workers, and in the lab. And all results received the expected results. We also found that about 2% of LAM strips produced invalid results. And we've also implemented this material for weekly QC testing just to see performance over time. So what did we learn from our experience with development of this EQA material? We know that urine is an ideal sample type, but we also know that it is not sterile. It contains bacteria and other pathogens and is therefore not the ideal sample material to be transported. We also found that we also determined that the material should be stable for transportation to remote areas, since this is where the LAM assay is intended to be used. There are also biosafety considerations. So we need to ensure that the material that is being shipped out is safe for transport and safe to the person who's going to be using them. EQA material should ideally mimic a clinical specimen, and it should be packaged so that the pipette provided of the LAM kit can be used for testing. So in a lab environment, this is a bit different. You have these repeat pipettes, and you have adjustable pipettes that can be used. So it doesn't really matter what your tube size is. But because of the difficulty with using the pipette that Jeremy showed earlier, we have to ensure that the packaging of this material allows for that pipette to be used. Because of the high numbers of invalid tests that we found, the volume provided should also be sufficient for repeat testing. And the number of samples and panels required per cycle is also important, because you need to ensure that all testing personnel participate. So like Jeremy said, it was easier for them to just train 2 nurses at their site, but is it going to be possible at all sites? This is something that needs to be taken into consideration. Then we have the cost effectiveness factor. So the LAM assay is not that it's relatively inexpensive. So if you have an EQA that's going to be 3 or 4 times more expensive than the product itself, how is that going to work? And then again, training. How do we ensure that everybody who's actually performing this assay is trained? We need to place more emphasis on train the trainer initiatives. Then do we need to also launch other initiatives, such as, I know in South Africa, the EID program has a nurse that drives around with panels and actually provides testing or provides retraining to staff as she moves through the different EID clinics. And then one of the other important factors is that the LAM EQA should be able to adapt it to the new LAM technologies that Morten mentioned earlier. So all in all, we need a robust and cost-effective EQA to support a sustainable program. And then when we go to reporting of results, there is no template for reporting of results. So currently, results are recorded in the patient file, and we know from discussions with some clinicians from other sites in South Africa, the negative results are not always documented. So if an EQA becomes available, this requires some kind of a reporting tool, and you have to have some kind of training videos or other kind of training material to ensure that the users of the LAM actually know that this is now a different method of reporting as compared to what they would usually do. And then, as Jeremy mentioned, there are also challenges with the result interpretation and your faint bands. And if you look at my 2 photos on the right, you see that it is not always easy to read these bands, especially because they're being read by people who, one person may see a band being present, another person may not. We know that this is problematic. And then when we look at the role of digital health technologies, this is something that we can't get away from. So basically, we have AI software that can be downloaded to a tablet, a mobile, or a reader. And this basically allows you to capture and store results digitally. You also have automated interpretation, and this can be easily used for continuous quality monitoring and surveillance. So at the moment, these are being used for COVID-19 and HIV, but there is no reason why we cannot adapt this, this kind of technology to TB, and especially on the LAM assay. So initially, the proof of concept was done by looking at the operator performing a visual read versus the interpretation that was provided by the software. So there is some documentation available that gives you a better idea of how this works. And there's also a TPP that was recently published by the WHO that is available for review. And if there are concerns regarding data storage and data security, our team has developed a self-declaration form that can help with this. And then when we look at result return, so online result submission will require a smart device and internet access. So are these available in remote locations? And then usually with assistance with troubleshooting, you would ideally want the user to be able to take a photograph of the results and upload. This again would require smart device and internet access. But is this going to be available in all settings where the LAM EQA is, or the LAM testing is being performed? And then finally, for my summary, so this test is performed in the field, but what level of support can be offered by the labs? The labs have experience with testing, and obviously if this can help with testing in the field, this is something that needs to be considered. We know that there are more questions than answers on some aspects of lab testing. And then I've done a quick search of available EQA for the LAM EQA, and I found that SmartSpot Quality is offering a EQA. So this consists of 4 vials that is sent out 3 times a year. And it consists of both MTB positive and MTB negative material. But then again, when we look at considerations, so are these number of panels going out sufficient? Are the number of vials being sent out sufficient? These are questions that we also need, or this requires a little bit more investigation to determine whether these EQA panels are actually going to work. And then I just want to acknowledge all the different people that have helped out with these studies. And that's it from me. Thank you.
Thank you, Anura, and thank you so much for all our presenters today, really for this excellent landscape overview of what LAM is and what it can achieve. And as we were saying, we need to really make sure that we can use all the tools which are in the toolbox for the diagnostic of TB to enable patients to have a timely access to treatment and therapy. And so I've seen that we had a number of questions in the chat. Some of them I think have been answered by Anura, and specifically I could see that some people had concern about the test being performed outside of the lab setting, and what was the role really of the laboratory. So I think Anura has really touched on that, and also the bridging, and the role that the laboratory can have in ensuring oversight of the quality of testing. Maybe just to step back a bit, and that question would be probably for Jeremy or maybe Leslie. Could you please just, in a few words, come back again to the indication for the TB LAM test, because some people were a bit concerned, had question regarding to what could happen when you are testing outside of the indication for TB LAM, and also the consequences of having, I think Anu had touched on this also, of having too long of an incubation period. And then finally, there were some concern pertaining to how the test eventually could not compete with the other tests that are available for testing. So maybe, I don't know which one of you would like to maybe address those different aspects.
Jeremy can maybe answer the clinical question, where it can be used.
Yeah, sure. So I'm just going to put the slide up again. So really for this audience, it's this middle column, the WHO recommendations to look at. But the concept here, just behind it, more or less, is that the sensitivity goes up as the CD4 goes down. And there's complicated reasons why that may be. It may be because of more dissemination to the kidneys and others. But in essence, this is really solving, and I see some of the questions in the chat were wondering, well, why we even bother with LAM? If I gave that impression, or if I've given the wrong impression, this is a fantastic test. It really does. It saves lives. We know this from multiple randomized controlled trials. It is often the only test we have to diagnose TB that tests positive, because as the CD4 goes down in advanced HIV, other diagnostic modalities like the gene expert are often less sensitive. And so you really do often find this is the only test that's positive. And it's even positive in settings where the clinicians don't suspect TB. Because one of the great challenges with a low CD4 count is that many of the typical manifestations of TB in the textbook don't manifest because the immune system is so compromised that it's unable to mount the sort of response that gives you those clinical manifestations. So this is really, it's a fantastic test. It just, the challenge is how to roll out, unlike every other test for TB, this is one that's not done by the lab, as all of the speakers have highlighted. And so the challenge is how to do that in a robust and reliable way. And that's what we've kind of hoped to address today. But it really does, we've had it for years. It's saved lives by the bucket load. This is a really, really important test. Thanks very much.
Thank you. I think you touched also on the other, there was that question about the clinical value in your setting, in your clinic, hospital, about early treatment. So how it can really fast track a patient being initiated on treatment, and also the risk reduction about mortality. Do you have some figure from the ground, from the field about that, maybe?
We don't have a mortality reduction figure in our hospital, because that we would have to trial to establish that. But in terms of the number of positive diagnoses of TB, it is almost, because of the advanced CD4. Remember that the median CD4 in our setting was 67. And so because of that, our LAMs account for almost as many TB diagnoses as GeneXpert does. And that, again, that's a particular setting of inpatients and low CD4s, which wouldn't necessarily be applicable to outpatients. But it is a key diagnostic for us, which, if we look at the overall positivity rate of the LAMs we do, I stand to be corrected, but I think it's about 15%, 15 to 20%. So basically 1 every 6 or so cases is that we are testing is testing positive. But again, understanding we have a very high burden of TB here, so that drives that. Thanks.
Thank you. Yeah, thanks. And thanks for reminding that really the choice of diagnostic tools that we are using for TB also depend on the settings where we are, the burden of TB, but also the burden of HIV. There was a specific question about what would you recommend to a setting which does not have access to CD4 count? So LAM would not be indicated there. Can you please provide some insight there as well? Thank you.
I'll start, but Chairman, I do want to open up to anyone else who wants to chip in. But so in fact, the guidance doesn't depend entirely on CD4. So CD4 is one of the criteria that can be used depending on inpatient or outpatient. But for example, the WHO recommendation for inpatients includes people with stage 4 HIV disease, or anyone who's seriously ill, irrespective of CD4 count. So as long as you know they have HIV, if they are severely enough ill, for example, that may qualify you for a LAM by a WHO criteria, even if you don't have a CD4 count. And that's very useful, because even when you can get a CD4 count, it often there's a delay. And the benefit of LAM is that you're able to do it soon. So for someone who's severely ill, let's say as an inpatient, that would be someone you don't need to wait for that CD4 count to do the LAM on. Thanks.
Thank you. Thank you so much. Professor Leslie, anything you would like to add, maybe?
Yes, thanks, Margareta. Thanks, Jeremy, and also Martin and Anura. I think there's just one question that I wanted to highlight is around the sensitivity of LAM versus GeneXpert. I think somebody is questioning why GeneXpert is less sensitive. And maybe just to highlight that, and Jeremy, you can support me here, is that LAM is also really indicated where you cannot obtain a sputum specimen from a patient. And remember that the GeneXpert is really designed for being used on sputum. There are a couple of papers and settings where it's being investigated on urine, and the performance, will pick up some, LAM will pick up some. But again, please just remember that LAM is used in the context of severely ill, and often where patients cannot provide that sputum, that can then not be tested on the GeneXpert. Jeremy, do you want to add to that?
Not to really add, just to support. I think that's such a key point, and thanks for bringing it up. In clinical practice, fewer than half of patients can produce an adequate sputum. And so it means that already straight out of the bat, you're massively decreasing the value of the GeneXpert in the setting. Again, it's a wonderful test. We love GeneXpert, but the practicality is everyone can produce urine, whereas fewer than half of people can produce sputum. And that really, again, shows the value of using these tests in a complementary way. They're not either or, but they really are, they're complementing, because those who who can't produce sputum, you've got at least another avenue for many of those patients to be testing for TB on. Thanks.
Thank you. So thanks again to all of our panelists. I think this presentation, there were many, have raised a lot of interest. As a reminder, they will be available on the ASLM YouTube channel. The slides will be also shared in our various groups. And we thank everyone for the assistance to the session. And on that, I think we've reached the end of the hour. So I would like to thank everyone again, and I wish you a very nice end of afternoon. Goodbye.